Welcome back to the Deep Dive, your shortcut to being truly well-informed. Today, we're embarking on a really crucial journey for any aspiring nursing professional. We're diving into a stack of insights from Lewis's Medical Surgical Nursing 12th edition to unravel the intricate world of rheumatic diseases. Think about it. Pain, inflammation, loss of function. These are realities for millions. Our mission today is to arm you with a fundamental understanding of these conditions, cutting through the density to give you the clearest picture possible for your nursing practice.
That's absolutely right. Rheumatic diseases, they significantly impact a patient's quality of life. I mean, affecting their mobility, energy, just overall well-being. Understanding the what, the why, and, especially the how we care is just paramount for effective nursing intervention.
Precisely. For you, our dedicated nursing student listeners, this deep dive is custom-tailored. We'll guide you step by step through the pathophysiology, risk factors, clinical manifestations, diagnostic tests, and, really importantly, the nursing management. We'll use straightforward language, emphasize that nursing process, and even verbally describe some key charts and, real-world scenarios from the text. So let's peel back the layers and understand what makes these diseases tick. So to kick us off, what exactly are we talking about when we refer to rheumatic diseases? What's the broad picture?
Broadly, these are conditions primarily affecting body joints, tendons, ligaments, muscles, and bones. The hallmark signs often include inflammation, persistent pain, and a progressive loss of function in these crucial connecting or supporting structures. The things that let us move.
And the scale of this issue is significant, isn't it? Are we talking about a widespread public health challenge here?
Oh, absolutely. Far from it being rare. The text highlights that over 54 million adults in the United States currently live with rheumatic conditions, and that number is projected to exceed 78 million by 2040. So, yeah, it's huge. This isn't just a collection of conditions. These are life-altering diagnoses. They profoundly challenge a patient's coping abilities because of limited function, chronic fatigue, altered body image, and, understandably, the fear of disability. This really brings home the question: how do nurses truly support patients facing such pervasive challenges, beyond just the medication?
That's a great point. Okay, let's start with the big one then. Osteoarthritis, or OA, often called wear and tear arthritis. It's the most common chronic joint condition. Can you walk us through what's happening inside the body with OA? What's the pathophysiology?
Sure. Osteoarthritis is a slowly progressive non-inflammatory disorder. That's key non-inflammatory. It primarily affects the diarthrodile or synovial joints. The core pathology involves the gradual loss of articular cartilage. That's the smooth protective tissue covering the ends of bones within a joint. The cushion, basically.
All right, the cushioning.
As this cartilage deteriorates, bony outgrowths, known as osteophytes, or bone spurs, form at the joint margins. Now, a crucial insight for nursing students here is that while aging is a risk factor, OA is not a normal, inevitable part of the aging process itself.
Okay.
Which means we have avenues for intervention. It's not just something you have to accept.
That's a really important distinction for patient education, isn't it? So what factors increase someone's risk for this kind of cartilage destruction?
The textbook outlines several key factors. Decreased estrogen after menopause might contribute to the higher incidence in aging women. Obesity is a significant contributor, especially for hip and knee OA, as it dramatically increases mechanical stress on those load-bearing joints. Makes sense, right? More weight, more stress.
Yeah, absolutely.
Additionally, joint injuries like an anterior cruciate ligament, an ACL tear, and occupations requiring frequent kneeling and stooping can significantly increase risk. This really underscores how deeply lifestyle choices and environmental factors can influence this degenerative process. It's not just bad luck.
Right. When we talk about how patients actually experience OA, what are the telltale signs a nurse should be looking for during an assessment? What does it feel like?
The cardinal symptom is joint pain. Characteristically, it worsens with activity. In early stages, rest can relieve it. That's a key difference. However, as OA progresses, patients may experience pain even at rest or have difficulty sleeping due to increased joint discomfort. This pain often becomes, a constant companion.
The text also highlights a specific kind of stiffness after rest. Can you describe that gelling phenomenon for us and why it's so important clinically?
Absolutely. That joint stiffness after periods of rest or maybe sitting in one position for a while, that's a classic sign, often called the gelling phenomenon. The key here is its duration. This early morning stiffness usually resolves within about 30 minutes.
Okay, 30 minutes.
Yes. This is a crucial differentiator from inflammatory disorders like rheumatoid arthritis, where stiffness lasts much, much longer. Patients might also report crepitation, that's a grating sensation caused by loose cartilage particles, particularly noticeable in knee OA.
And what about how the joints actually look? Can you see changes?
You can. Deformity is specific to the involved joint. In finger joints, for example, this osteophyte formation can lead to Heberden nodes on the distal interphalangeal joints, the DIP joints.
The ones near the fingertips?
Exactly. And Mouchard nodes on the proximal interphalangeal joints, the PIP joints. These can actually look red, swollen, and feel tender. In knee OA, cartilage loss might result in a bow-legged look that's varus or a knock-kneed look valgus appearance. Critically, OA typically affects joints on one side of the body, making it asymmetric.
Asymmetric. Okay.
And it does not present with systemic symptoms like fatigue, fever, or organ involvement. Another vital distinction from RA, no systemic signs.
That's huge for differential diagnosis. So how do we confirm a diagnosis of OA, especially when symptoms can vary so much between people?
Well, X-rays are crucial for confirming the disease and staging the joint damage. They'll show things like joint space narrowing and those osteophytes we mentioned. However, the text emphasizes a really critical point for nurses. These X-ray changes don't always correlate with the patient's pain level.
Interesting.
Yeah, some people with significant findings on X-ray have few symptoms, and vice versa. You can't just look at the picture. Synovial fluid analysis, if it's done, helps differentiate OA. In OA, the fluid is typically clear yellow with minimal inflammation. And importantly, there are no specific lab tests that directly diagnose OA. It's more clinical and radiographic.
Got it. So for us as nurses, what does all this mean for managing OA? What's our role in helping these patients live better with it?
Right. Since there's no cure, nursing care is squarely focused on managing that pain and inflammation, preventing disability as much as possible, and maintaining or even improving joint function. It's a really holistic approach, encompassing both pharmacologic and non-pharmacologic strategies.
Okay, let's dive into some of those key interventions. What are the cornerstone approaches a nursing student really needs to master for OA management?
Okay, first, pain management. For many, topical agents like capsaicin cream, which works by interfering with substance P, a pain transmitter, or diclofenac gel, are often first line.
Topical first. Interesting.
Yes, less systemic exposure. Then you have oral non-steroidal anti-inflammatory drugs, NSAIDs like ibuprofen or celecoxib, but nurses must educate patients on potential gastrointestinal or GI side effects, especially with those targeting GAIOX-1, an enzyme crucial for protecting the stomach lining. It's also really important to caution against combining oral and topical NSAIDs without medical guidance, because that increases the risk of adverse effects.
Good point.
For localized inflammation, sometimes an intra-articular corticosteroid injection right into the joint can offer relief. But systemic corticosteroids, generally avoided as they can actually worsen the disease long term.
Okay. And beyond the meds, what about non-pharmacologic therapies?
Equally vital. Heat therapy is excellent for stiffness. It increases flexibility and blood flow. Think hot packs, whirlpools, or maybe paraffin baths for hands. Ice can be used for acute inflammation and swelling. Cold for acute, heat for stiffness. Weight management is another critical intervention, particularly for patients with hip and knee OA. It just takes the load off. So we guide patients in evaluating their diet and creating a sustainable weight reduction plan. Small changes can make a big difference.
And exercise. Is that safe?
Absolutely, but the right kind. Aerobic conditioning, range of motion, or ROM exercises, and muscle strengthening are encouraged. Strong muscles support weak joints. A physical therapist can tailor a specific program, and balancing exercises like Tai Chi are actually very beneficial. We also emphasize rest and joint protection. Patients need to learn to balance rest and activity, pacing themselves. During acute inflammation, resting the affected joint with splints or braces can help. The textbook has an excellent table, Table 69.4, on joint protection and energy conservation. It recommends things like maintaining a healthy weight, using assistive devices, canes, walkers, avoiding forceful repetitive movements, and using good posture.
So practical advice is key.
Absolutely. Our role here is to teach patients about the disease itself, pain management strategies, proper body mechanics, and how to use those assistive devices effectively. This comprehensive education really empowers them in their daily lives.
That's a great overview of OA management.
Yeah.
Now let's shift gears to rheumatoid arthritis, or RA. You mentioned it's different from OA's wear and tear. You called it a systemic autoimmune disease. What truly distinguishes RA?
Right. RA is a whole different beast. Like you said, it's a chronic systemic autoimmune disease marked by inflammation of connective tissue, primarily in the synovial joints. It's characterized by periods of remission and exacerbation flares and quiet times. And crucially, it often involves extraarticular manifestations.
Meaning outside the joints.
Exactly. It affects more than just the joints. It's considered one of the most disabling forms of arthritis. It affects about 1.5 million adults in the U.S., and women are almost 3 times more likely to develop it, typically between ages 30 and 60. That systemic involvement is a major differentiator from OA.
Okay, so if it's an autoimmune disease, what's precisely happening at the cellular level that causes this widespread inflammation and damage?
The exact trigger isn't fully known, but the leading theory involves a combination of genetics and environmental factors triggering an autoimmune response. Basically, in genetically susceptible individuals, some antigen, we don't always know what, triggers an immune response. This leads to the formation of abnormal immunoglobulin G, or IgG. Then, autoantibodies, specifically something called a rheumatoid factor, RF, combine with this abnormal IgG to form immune complexes.
Okay, immune complexes.
These complexes then deposit on the synovial membranes in the joints, activating a big inflammatory response. Neutrophils and other inflammatory cells rush in, releasing proteolytic enzymes and enzymes that break down tissue, which damage the articular cartilage and cause the synovial lining to thicken. Plus, pro-inflammatory cytokines like IL-1, IL-6, and TNF tumor necrosis factor further drive this inflammation. It's really a classic example of the body's own immune system turning against itself, leading to chronic destruction.
Wow, that sounds like a destructive cycle.
Yeah.
How does this cellular chaos manifest in the patient? What symptoms should a nurse recognize as potentially RA?
Well, the onset can be subtle, insidious even. Non-specific symptoms like fatigue, anorexia, weight loss, and general stiffness often precede actual joint involvement. Patients might just feel unwell for a while.
Vague symptoms first, potentially.
Yes. When joint symptoms do appear, they are typically symmetrical, that's a key word, affecting both sides of the body, both hands, both wrists, both knees. And it frequently involves the small joints of the hands, specifically the PIP and MCP joints, and the feet, the MTK joints.
That symmetry is a critical difference from OA, like you said. And what about the morning stiffness here compared to OA's short-lived gelling phenomena?
Ah, yes. Big difference. Unlike OA's 30 minutes, morning stiffness in RA can last from 60 minutes to several hours, or even longer, directly depending on how active the disease is at that time.
Hours, okay.
Joints are often swollen, tender, and feel warm to the touch due to the inflammation. And as RA progresses, this chronic inflammation and fibrosis can lead to significant joint deformity and disability. Common deformities you might see in the hands include ulnar drift, where the fingers angle towards the ulna, sometimes called a zigzag deformity, swan neck, and boutonnière deformities. The textbook has some clear images of these, like in Fig 69.4.
Now, this is where that systemic aspect really comes into play. Beyond the joints, what other body systems can RA affect? This is crucial for assessment.
It really is. RA can affect nearly every body system. Patients may develop rheumatoid nodules. These are firm, usually non-tender masses, often found on bony areas like the elbows or back of the hands. Sjogren's syndrome, characterized by dry eyes and dry mouth due to immune attack on moisture-producing glands, is a common extraarticular manifestation.
Dry eyes and mouth, okay.
Felty syndrome, though rare, can occur. This involves an enlarged spleen and a low white blood cell count, which significantly increases the patient's risk of infection. And importantly, that chronic inflammation isn't just in the joints, it can accelerate atherosclerosis hardening of the arteries. This increases the risk of heart attack by about 60% compared to people without RA.
Wow, 60%. That really demonstrates why a comprehensive head-to-toe assessment is so vital in these patients.
Absolutely, you have to look beyond the joints.
With such a complex, widespread disease, how do we actually nail down the diagnosis?
Diagnosis is often made based on a combination of the patient's history, physical findings, and specific criteria set by the American College of Rheumatology. Lab tests are crucial here.
Yeah.
A positive rheumatoid factor, or RF, is found in about 80% of adults with RA. But even more specific are anti-citrullinated peptide antibodies, anti-CCP. They're present in about 80% of patients and can appear early.
Anti-CCP, good one to remember.
Yes. Also, elevated ESR erythrocyte sedimentation rate and C-reactive protein, or CRP, indicate active inflammation, but they're not specific to RA. Synovial fluid analysis, if done, typically shows cloudy, straw-colored fluid with fibrin flecks and increased white blood cells reflecting the inflammation. And X-rays. Initially, they might just show soft tissue swelling, but later they progress to show joint space narrowing, bone erosion, and eventually deformity.
This sounds like aggressive early treatment is absolutely necessary to prevent that long-term damage. What does nursing management entail for RA?
You're right, early and aggressive treatment is key. The goals are similar to OA, but often more intensive because of the systemic nature and potential for severe disability. We aim for acceptable pain management, minimizing loss of function, ensuring the patient can participate actively in their care, helping them maintain a positive self-image despite the challenges, and performing self-care to the maximum extent possible.
Okay. And what are the cornerstone treatments, especially from a pharmacologic perspective? What do nursing students need to know about the drugs?
Drug therapy is paramount in RA. Disease-modifying antirheumatic drugs, or DMARDs, are the foundation. These are prescribed aggressively and early to slow disease progression and, crucially, reduce joint erosion. Methotrexate is often the preferred initial DMARD due to its efficacy and relatively lower toxicity risk, although it does require frequent monitoring, complete blood count, CBC, and liver function tests.
Okay. Methotrexate often first. What else?
Then we have the biologic response modifiers, or BRMs, also called biologics. These are typically used for moderate to severe RA, especially if traditional DMARDs aren't cutting it. They are more targeted, specifically going after parts of the inflammatory pathway. Examples include TNF inhibitors like etanercept, interleukin receptor antagonists, and JAK inhibitors. Now, nurses must be acutely aware of the drug alert associated with BRMs in the textbook. It highlights the increased risk for infection.
Next risk, right?
Big time. Patients usually need tuberculin skin tests and chest x-rays before starting therapy to rule out latent TB, and they absolutely need to avoid live virus vaccines while on these drugs.
That's critical patient teaching. What about other meds?
Other drugs like NSAIDs and corticosteroids are used symptomatically for pain and inflammation, kind of like an OA, but they don't alter the underlying disease course like DMARDs and biologics do. They're for symptom relief.
Got it. So beyond the powerful medications, what other nursing interventions are vital for a patient living with RA day to day?
Self-management strategies are really key to daily living. Rest and energy conservation are crucial. Fatigue is a huge issue in RA. Alternating scheduled rest periods with activity, what we call pacing, helps manage both fatigue and pain. Maintaining good body alignment during rest, using a firm mattress, and avoiding prolonged flexion, like keeping knees bent for hours, are important to prevent joint contractures.
Protecting the joints themselves must be important too.
Definitely. Joint protection is vital. The text has another useful table, Table 69.12, with specific instructions for protecting small joints. Things like maintaining a neutral position when possible, using the strongest joint available for a task like carrying things with your palms open instead of gripping tightly, distributing weight over many joints, changing positions often, and avoiding repetitive movements that stress one joint. Heat and cold applications are helpful, similar to OA. Gentle range of motion exercises, especially in warm water like a pool, are encouraged to maintain joint function. But caution is needed. Don't overdo it during an acute flare-up.
Makes sense. What about diet?
Nutrition-wise, a balanced diet is important. Fatigue and pain can lead to appetite loss, or conversely, corticosteroid use can lead to weight gain, so monitoring is needed. And what's perhaps most critical here, connecting back to our earlier point, is the psychological support. Living with chronic pain and potential disability often requires significant emotional and financial support. Referring patients to self-help groups and counseling can be vital resources. It's truly a holistic approach needed for RA.
That holistic view is so important. Okay, let's quickly turn our attention to gout. A distinctly different type of arthritis, right? What's the core issue here?
Yes, gout is different. It's characterized by hyperuricemia, that's an elevation of uric acid in the blood, and the subsequent deposit of uric acid crystals, specifically monosodium urate crystals, in one or more joints. It's notorious for incredibly painful flares, attacks that can last days to weeks, followed by symptom-free periods. It affects more men, typically hitting them between 30 and 50 years old.
So why does uric acid build up in the body to cause these agonizing attacks?
Good question. Uric acid is the end product of purine catabolism. Purines are substances found in our cells and in certain foods. Normally, it's excreted by the kidneys. Gout occurs either when the kidneys can't excrete enough uric acid or there's an overproduction of it, or sometimes a combination. Risk factors include metabolic syndrome, that cluster of conditions like obesity, high blood pressure, insulin resistance, also a diet high in purines.
Which foods are high in purines?
Things like red meat, organ meats, shellfish, and also fructose-sweetened drinks. Alcohol consumption, especially beer, is a big trigger for many. And certain drugs, like some diuretics, can also raise uric acid levels. It's striking to realize how seemingly unrelated lifestyle choices, what you eat and drink, can directly impact joint health so dramatically in gout.
And what's the classic manifestation that just screams gout? to a nurse assessing a patient?
The absolute classic is acute inflammation of the great toe joint. It even has a name, podagra.
Podagra, yeah.
The affected joint appears dusky or cyanotic, very swollen, and is exquisitely tender. Even the pressure of a bed sheet can be unbearable. In chronic gout, if it's not well managed, you can get visible deposits of these sodium urate crystals under the skin. They're called tophi. They look like hard white nodules, often seen in places like the ears, elbows, or fingers. 69.6 in the text shows this well. These tophi can lead to joint deformity and even contribute to kidney stones.
Yikes. Okay, how do we treat it, both for those acute painful attacks and for long-term prevention?
For acute attacks, the goal is rapid pain relief. Oral colchicine, which is an anti-inflammatory specific for gout crystals, and NSAIDs are the go-to treatments. Sometimes corticosteroids are used too. For prevention, to lower uric acid levels long-term, we use drugs like xanthine oxidase inhibitors. Allopurinol is the common one. They work by decreasing the body's production of uric acid. There are also uricosuric agents, like probenecid, which increase the kidney's excretion of uric acid. But a key teaching point here. Patients on uricosurics must avoid aspirin because aspirin actually inactivates the effect of those drugs.
Oh, important drug interaction.
Very important. So nursing education focuses heavily on limiting alcohol and high purine foods, maintaining good hydration to help flush uric acid, and achieving a healthy weight. Lifestyle is huge in gout management.
Great summary. Okay, let's unpack one of the most complex and often unpredictable conditions we're covering. Systemic lupus erythematosus, or SLE. You described it as a multisystem inflammatory autoimmune disease.
Indeed, SLE is really complex. It results from intricate interactions among genetic, hormonal, environmental, and immune factors. It's chronic and notoriously unpredictable, with flares and remissions. And it affects multiple organs: the skin, joints, serous membranes like the pleura around the lungs and the pericardium around the heart, kidneys, blood cells, and the nervous system. It primarily affects women, about 90% of cases, often striking between the ages of 15 and 45. The deep dive here really involves recognizing the devastating potential of these uncontrolled autoimmune responses across the entire body. It truly earns its nickname as the Great Imitator because its symptoms can mimic so many other illnesses.
Given that it's autoimmune, what's happening at the fundamental level inside the body in SLE? What's the core mechanism?
The body basically fails to recognize self. It produces various autoantibodies against its own components, especially against elements within the cell nucleus, like DNA. Anti-nuclear antibodies, or ANAs, are common. These autoantibodies then form circulating immune complexes with the antigens they're attacking. These immune complexes then deposit in the basement membranes of capillaries in various organs: kidneys, heart, skin, brain, joints, triggering inflammation and subsequent tissue destruction wherever they land. This widespread deposition is what leads to the multisystem effects.
With so many systems potentially involved, what are some of the key clinical manifestations our nursing students should really be aware of when assessing a patient?
The severity varies hugely, from mild to life-threatening. Classic signs that often bring people in include the butterfly rash, technically called a Meller rash, across the cheeks and the bridge of the nose. It often resembles a sunburn. Fig 69.10 in the text shows it well. Photosensitivity developing a rash after sun exposure is also very common. Patients frequently experience polyarthralgia, which is pain in multiple joints, often with morning stiffness, similar to RA. However, SLE-related arthritis is usually non-erosive, meaning it doesn't typically destroy the joint bone like RA can.
Okay, non-erosive arthritis. And beyond the skin and joints, what are some of the more serious organ system impacts we need to watch for?
Renal involvement is a major concern. It manifests as proteinuria protein in the urine, or glomerulonephritis, inflammation of the kidney filters. This affects about 40% of patients and can, unfortunately, lead to end-stage renal disease. It's a leading cause of morbidity and mortality in SLE.
Kidney damage is a big one then.
Huge. Cardiopulmonary issues like pericarditis, inflammation of the sac around the heart, and dysrhythmias are also serious. And, similar to RA, accelerated atherosclerosis means heart disease is also a leading cause of death in SLE patients. Neuropsychiatric manifestations are also common and varied. They can range from headaches and peripheral neuropathy to seizures, psychosis, and cognitive impairment, sometimes called lupus fog. And patients also have an increased susceptibility to infection. This is due to both the impaired immune function from the disease itself and the immunosuppressive drug therapies used to treat it. Infection is a major risk.
So managing SLE seems like a real balancing act. What's our critical role as nurses?
It is a balancing act. A major challenge is managing the active disease while simultaneously preventing complications of the treatment itself, especially from immunosuppressants. Nurses play a critical role in meticulous assessment, monitoring for flares and complications, and providing comprehensive patient education.
Can you highlight some of those key nursing assessments specifically for SLE? What are we looking for?
We meticulously assess for signs of a disease flare, monitoring fever patterns, joint inflammation and limitations, the location and degree of discomfort and fatigue levels, which can be profound. We monitor weight, fluid intake, and output very closely, especially if corticosteroids are prescribed, because of the potential for fluid retention and, importantly, those renal issues. Observing for signs of bleeding bruising, petechiae is also crucial due to potential effects on blood counts and some drug therapies.
And the neuropsychiatric aspects.
Yes, given the wide range of neuropsychiatric manifestations, carefully assessing for vision problems, persistent headaches, personality changes, seizure activity, and memory loss is essential. Psychosis can actually result from central nervous system involvement or sometimes be a side effect of high-dose corticosteroids. We need to differentiate, and peripheral neuropathy might cause numbness, tingling, and weakness.
This really raises an important question. With such a challenging, unpredictable disease, how do we empower patients to live full lives? What's key for them?
Education is absolutely paramount. We teach patients about their specific trips for flares, things like excessive fatigue, sun exposure, so sunscreen and protective clothing are vital, emotional stress, infection, certain drugs, and even surgery. We help them develop strategies to eliminate or reduce exposure to these triggers. They absolutely need to understand their drug therapy, proper administration, potential side effects, and critically, why abruptly stopping medications, especially steroids or immunosuppressants, can be dangerous and worsen disease activity. Adherence is key.
And beyond the physical.
Beyond the physical, providing emotional support is huge. Assisting with activity planning to conserve energy and discussing sensitive issues like marriage, career planning, and pregnancy counseling are also critical. SLE has a major impact on all aspects of a patient's life, and we need to address that.
Wow, we've certainly journeyed through some truly complex territory today. From the localized wear and tear of osteoarthritis to the systemic attack of rheumatoid arthritis, the uric acid surges of gout, and the really multifaceted challenge of systemic lupus erythematosus.
Yeah, what really stands out here, I think, is the critical role of the nurse, recognizing these distinct patterns, understanding the subtle and sometimes not so subtle differences between these conditions, providing that holistic, patient-centered care, and crucially, empowering patients through education for effective self-management. It's really about making a tangible difference in their quality of life, whether that's through meticulous pain management, teaching joint protection strategies, or helping them navigate these complex drug regimens safely.
Absolutely. These conditions truly underscore the importance of comprehensive patient assessment and really tailored interventions. There's no one-size-fits-all approach here. So as you, our listeners, continue your learning journey, maybe consider this. Beyond the clinical manifestations and the lab values we discussed, how do these chronic, often invisible diseases uniquely impact a patient's identity, their sense of self, their place in the world? What more can we as future nurses do to support not just their physical health, but their emotional and social well-being in a truly meaningful way? Something to think about. Keep digging, keep asking questions, and keep learning. We'll catch you next time on The Deep Dive.